What a beautiful crowd. It's so nice to be here. My name is Dr. Sheila Wijayasinghe. I am the Medical Director of Primary Care Outreach at Women's College Hospital, and I have a family practice at St. Michael's Hospital here in Toronto. I've had the honor of being a family doctor for close to 20 years. And for those of you maybe doing the mental math, I am firmly in my perimenopause years, as is my pelvic floor right now, because I really have to go to the bathroom. So being on this stage with you and being in perimenopause with all of you in the room, has made me really reflect on being a patient myself and how I interact with my patients and how I provide care to them. I want to share a little story because I'm really learning about menopause as well every day. About 5 years ago, a patient came to me requesting menopause hormone therapy. She had done her research and trusted me to help her. I listened, I empathized, but I did not act. Like many doctors of my generation, I was taught to avoid hormone therapy, and I felt unsure of how to support her. Looking back, I know that wasn't enough. When I saw her recently, I apologized and thanked her for helping me to do better for her moving forward and for my other patients as well. Many of my menopausal patients have shared stories that they have been dismissed in the healthcare system, that their symptoms are in their head, and that there's nothing that we can offer for support. This is unacceptable, but all too common. And while there are many symptoms of menopause that can leave you feeling quite depleted, I also want to share some good news. Women in midlife feel more confident to speak their truth and cut through and filter out what is not helpful for them. And because of this confidence, there has been a wave of menopause momentum in the public spaces, on social media, and we as doctors and healthcare are catching up to this wave. And so I ask all of you, while doctors are unlearning and relearning how to provide good menopause care, we need your help to do better. And that's what I'm here to do today, is to try to help you discuss the concept of self-advocacy in doctors' offices. The healthcare system can be difficult, and hopefully using this tool, I've created an acronym called PARTNER, as in healthcare partner, or sexual partner if you want, but healthcare partner is a little bit more what we're talking about, to help you navigate your menopause care moving forward. As it's been said before, menopause is a normal part of life, but suffering through it is not. So I'm hoping that by having this acronym handy, you can get through those visits. So first off, the P of partner is to prepare for your appointments. You may have 10, 15 minutes if you're lucky with your doctor or nurse practitioner. So you want to track your symptoms ahead of time, think about what your goals are of your visit, and come in prepared. You can find a really amazing tool at the Menopause Foundation of Canada, which will give you a tool to help write down your symptoms and bring it in with you. The A is ask for the right support. Many of my colleagues want to support their patients, but not all are comfortable managing menopause symptoms. If your provider is open to learning with you, you can bring in resources as well from reliable sources like the Canadian Menopause Society. They have a wonderful book called the Sigma Menopause Guide. It's reliable, it's helpful. Or you can also go to the SOGC, which is the Society of Obstetricians and Gynecologists of Canada site, and they can also have something called menopauseandyou.ca, and you can share information from there. If you do not have a family doctor like the millions of Canadians who unfortunately do not, you can find a menopause provider through the Canadian Menopause Society, or you can also go with the help of a virtual platform or a menopause clinic that have trained providers. R is to recognize your rights as a patient. The patient-doctor relationship has evolved from a one-way street of a doctor telling their patients what to do, to now shared decision-making. You have a right to ask questions. You have a right to ask for clarification. You are an equal part of this conversation, and you know your body best. T is to talk openly about tough topics. We don't talk enough in medicine about the social determinants of health. Things like housing, income, and the basic access to basic necessities. These all play a huge role in patient outcomes. I recently had a patient who wasn't improving on her hormonal therapy. When we dug deeper, she admitted that she had been taking her medication every other day to stretch it out because it was simply too expensive. With the rising cost of living, medication can be unaffordable. We as healthcare providers should ask about the cost and if it's affordable every time we give you a prescription, but if we do not, please let us know. This is also my plug for a national pharmacare plan that I'm hoping will come in at some point. If we do not ask, let us know, so we can offer cost-effective options, work with our pharmacy colleagues to try to find other options that may be available to you, and collaborate with you, or we can also suggest financial support programs to ensure that you're getting the medication that you need. Along the same lines, let us know if your income is being affected, as we've heard also tonight, by menopause symptoms. Whether it's struggling with sleep or hot flashes affecting your work, let us know. I write many letters for my patients to say maybe they can work from 10 to 6 instead of 9 to 5. If your workplace allows that, it's a really great opportunity, and we're happy to do that for you. Also, can we talk about sex a little bit more? Sexual health is a crucial part of our overall well-being, but many women hesitate to bring it up with their healthcare provider despite wanting to talk about it. One of my patients struggled with painful intercourse due to genital urinary syndrome of menopause, and so I prescribed her a vaginal estrogen cream. I saw her a couple of months later, and she said I hadn't even used it. And I asked her why, and she said, Dr. Sheila, I don't even know where to put it. I don't know what it looks like down there. I'm not comfortable. I appreciated her sharing that with me, because then together with a mirror that I keep in my office, we reviewed how to use it, which gave her the confidence to start using it, and her symptoms improved. What held her back is what holds many of us back: the shame about sharing that we may not know about our own anatomy and that we may not be comfortable to talk about sexual health. But these are the conversations that can change outcomes, so we need to lean into the discomfort and normalize these discussions. N of partner is numbers are important. But beyond managing menopause symptoms, we must prioritize heart and bone health, because risk factors accelerate during our midlife. In Canada, a woman dies from heart disease every 22 minutes. You can take control by managing your risk factors. So know your blood pressure, know your blood sugar, know your cholesterol. These are all really important numbers to know, and with prevention, it starts with awareness. E is to ensure that it's not just menopause. The pendulum has swung from nothing, never talking about menopause as a cause for symptoms, to everything is about menopause or perimenopause. But it's important to know that fatigue can be from sleep apnea, low iron or thyroid issues. Night sweats can be from heart disease or cancer. If your healthcare provider is simply giving you a prescription without reviewing other causes, ask them and make sure that other causes have been ruled out. Finally, R is to review all options for treatment. Hormone therapy is a hot ticket discussion right now. Everyone feels like they need to be on it, but there are other options that are available for support, like lifestyle management and also non-hormonal options. This is especially important if you have a medical issue that may not allow you to be on hormone therapy, or you simply don't want to be on hormone therapy. Finally, it's important to acknowledge that while these tips may be helpful, the partner model may not always apply. Our healthcare system is complex and often labels patients as difficult, when in reality, it is a system that can be difficult. And our healthcare system does not treat everyone the same. Systemic racism, particularly anti-Black and anti-Indigenous racism, remains pervasive. We see this in the disproportionate struggles of Black and Indigenous patients to access care, even when they experience more severe symptoms of menopause and are at higher risk for long-term health implications. Healthcare settings should be culturally and emotionally safe spaces. And while we are working on this with training and understanding and acknowledging our biases, we still have much work to do. So for those of you who face these additional barriers, I encourage you to bring safety with you to your appointments, whatever that looks like for you. It may be bringing a list of questions to ask or a notebook to write down things to review afterwards. It can look like bringing safety in the form of a support person, an ally that can be a second set of ears and backup support. I believe that many of my colleagues want to be better advocates for our patients in midlife, but the reality is we haven't been given the training to do so. To put that into perspective, the time we'll spend together tonight at this event is longer than the menopause education that most of us have received in medical school. But that doesn't mean we can't change. Our mothers couldn't ask the questions, but we can. And with patients being willing to advocate and doctors being moved to learn, we can, together, raise the standard of care for women in midlife. Thank you.